So any questions on repro?
Hi, Ms. Jones. This is Jessica. In the aspect of human development,
Yes.
just to clarify, it is across the lifespan, or is it only in geriatrics? Because even like on exam 4, when it came to like grief and loss in regards to human development, I was a little confused on whether it starts from the point of like, birth to the end of life. So is it across the lifespan, or are we focusing specifically on only newborns, since it is reproduction and it has a lot to do with newborns?
No, we're going to focus across the lifespan because we're going to talk about fetal demise. We're going to bring up the death in pediatrics with our SIDS in end of life and grief. We'll also be talking about children with congenital defects. That's part of grief. And then it's back in human development when we first introduced things like Down syndrome, autism, cerebral palsy, CP, all of those. So all of it sort of does go across the lifespan. Now, in your repro section under sexuality, you had a good section on aging. Should have probably talked about menopause, and then ED in the male, some of those aging aspects. So across the lifespan, but if you look at your exemplars, I think we've picked out fairly specific examples. So we're not talking about the normal growth and development of the preschooler, toddler, child kind of thing. We're looking more at abnormal development and picking up the exemplars like ADHD, CP, Down syndrome. And then end of life can be any age. So we can be fetal demise to SIDS to all the way up to MI. I think were some of our exemplars there.
Okay. Thank you.
You are welcome.
So there was a question about the statistics. I think there was a myth regarding STIs and whether or not they're equally across all groups of folks. And the truth of the matter is there is a population of people where STIs are more prevalent. And so I don't know if it's necessarily statistical, but it's more of understanding what type of patient population you have, what group you're working with. I mean, STIs across the board, when you're talking about head or sex education or sex health or education, or what is it, health education, depends on whatever they title it. But that is definitely, I'm learning that's something that's not even taught in high schools anymore, where, I know we had to take a sex education course, health education, but that all included the STIs, et cetera. That was a part of it, drugs and alcohol. But, I wouldn't necessarily focus on that piece. I would just focus on understanding who's more at risk for developing STIs and why. And then what do we do about it? I'm sorry? What do you mean? I mean, according to your book clearly outlines that it is African Americans. So if it was a question related to STIs, it came directly out of your textbook, out of the Reese book. So it's not my personal answer. It's what the statistics are showing. So when you read your concept for that, it definitely explains it there.
And I think, Nikki, it depends on lifestyle behaviors too. So any age is more at risk if they're engaging in sexual activity extensively and unprotected sexual activity. Yes, they're going to be at more risk whether they're an adolescent, young adult, older adult. So that's going to be a risk factor that's across the lifespan as well. And then I think another thing and Ms. Hudson can correct it if it's not something you talked about, but usually we also look at what do you do for a female that usually they're the ones getting treatment that's being treated for an STI, or STD, whatever you want to call that. So what are the parameters that she has to abide by to be treated? What do we tell her?
That is true, and it is more women that they're now calling, instead of STDs, STIs. So that's the new nomenclature for it. So,
Woohoo! Gotta be correct here.
but I mean, there were other conditions that was a part of that, like Huntington's disease. So if you look at your exemplars, there were specific exemplars that was related to that whole section, not just repro, but I think it was it interpersonal relationships, sexuality and human growth and development. So this was fall under human growth and development. So don't overlook those.
Huntington's, sickle cell were there. Downs, of course, is part of that. I think breast cancer briefly, but that's going to be covered more in cellular regulation. Right. Ms. Hudson's correct. Don't ignore the inherited, because we did talk about that. Why would even a pregnant woman be tested for possible genetic disorders? So, and the difference between being a dominant, autosomal dominant, to autosomal recessive, to sex-linked, I would review those methods of genetics. Would you say that's correct, Ms. Hudson?
I would agree.
Okay, yeah.
And I think that's where their focus was more on the repro, and they missed the human development component, if I remember correctly. Yes, Jessica?
Sorry, that was a mistake. My question answered. Sorry.
Oh, okay.
Well, that's good.
Yes, Rebecca.
Yes, I had a question with reproduction being the concept, but our exemplar is pregnancy. And to me, that just seems like a huge, broad category. Would you be willing to tell us what to focus on? Is it just everything prenatal, risk conditions, or labor and birth, problems with labor and postpartum? Is it just everything?
The quick answer is yes. However, I would know you want to think about the fact that our focus is going to be understanding the quote normal, but we're looking for what doesn't fit that pattern, so we know what to do with someone who presents differently, like your placental abruption or your previa. They're two different things. So that's an easy answer maybe, and yet it is all of it, yes. But you need to have the basic knowledge of the normal, but we're not going to probably ask you the stages of labor at this point. We want to know if you have a mother who's in labor and we're not having any descent, what do you anticipate being done? So it's more looking at the problems that come up and how you're going to respond to it as a nurse.
That's helpful. Thank you.
You're welcome.
Talking and my mic wasn't on. So there were a couple questions. What medications can you not take if you take erectile dysfunction meds?
Well, one is alcohol. Of course,
Nitroglycerin for sure, because those are vasodilators. So any vasodilators you cannot take with erectile dysfunction and medications, and you need to find or ask the patient if they've used those within the last 24 hours. So that would also include your Levitra, your Cialis would also be those as well. So anything that causes vasodilation would be the ones you don't want to take, because the beta blockers will fall under that category. And that would be because your erectile dysfunction medications causes vasodilation. So if you now take a vasodilator, now you have a double bump in vasodilation. So it's a more potent effect. So the person can end up with profound hypotension. Does that answer your question? I think that was Nikki. Okay. All right. And then Danielle Zahn, you ask, can you explain X-linked genetics and what specifically do you need clarification on? X-linked means it comes from the mother. Is that what are you speaking on a specific one like hemophilia?
No, I think I was just trying to figure out like the percentiles, like if a carrying mother has a boy and a girl, who's more likely to get that characteristic?
If it's sex linked, if it's female? Is that what you're asking?
Yes. Yes.
Okay. So
Both.
what is the genetic makeup of the female? What are we? Initials.
XX, double X.
Yeah, okay, yeah. So what is the male? XY. So then, you do your little box, but if the child, in order to carry the gene, depends on if it's dominant or recessive, of course. If it's recessive, then only there's no actual disease with it if the male has none. They'll be carriers. But if it's dominant, then we can pass it to half of the children, technically. You cannot use paper, but you can use your note that you can use in Exemplify. You have like a notepad. Isabella,
Go ahead.
the opposite. Okay, so if mom is negative, yes.
Ms. Johns.
If both are negative, we're absolutely fine with RH incompatibility. But if mom is negative and dad positive, then we need to administer the RhoGAM. That is correct.
I have a question. In regards to RhoGAM, I'm not sure if I read it correctly or if I made the right assumption. But in the case that you don't know if the mom is positive or negative, you give it either way prophylactically, correct?
Say that one more time.
If you're unaware if the mom is of the RH compatibility, if you're not sure if they are or they're not, you give the RhoGAM prophylactically, correct?
If mom is negative, you mean?
If you don't know.
Not usually. If we don't know about dad, if mom is negative, we will give it. But if mom is positive, if mom is negative, did I say that wrong? Yeah, if mom is negative, we will if we don't know anything about the dad. But if mom is positive, we don't have a problem.
Okay.
We don't usually just give it without at least knowing one of them. And then it will be given for subsequent pregnancies as well. Oh, there's Miss Smith too. Awesome. It's all of the pregnancies, once it's been determined that we have a incompatibility with negative mom, positive dad. Now, if there's a different father, we can check the father. We have two negative. But usually if mom was negative but dad positive, we gave the RhoGAM, we have set up some, mom has already have some of that in her makeup. So we usually go ahead and do RhoGAM. If mom and dad are both negative, no RhoGAM needed. But if there's this, the next pregnancy could be different. Just saying. Anything else on, you have Miss Smith now, so any other questions on repro that you'd like to ask about?
Yes, I have a question on STIs. I guess Ms. Hudson talked about it already, and in regards to kind of knowing what population is at risk and the overall care for them. But there was quite a few under that. I feel like STI is just kind of like an umbrella term because there's various different ones. And I remember Ms. had made like some sort of chart for us to know like the infectious period and latent period and stuff like that. So I don't know if that would be something that we should focus on as well, or just like the incubation, if you will. I know specifically for syphilis, there's like phases. I don't know if that would be important or not.
Mrs. Smith, would you like to speak to that?
We did the chart to give you a way to pull all that information together. Typically looking at what are, the top 3 or 4 leading STIs is the way I was looking at it, and more the signs and symptoms and the nursing interventions, and what are we doing for them, especially with, say, gonorrhea and chlamydia, that we treat for both of them, even though we may only have the diagnosis for one because they are usually co-infected, and using a one-time dose that we observe the medication being taken to try to get control of things. Yes, and as you said, those at-risk populations, I wouldn't spend an extraordinary amount of time, I don't think, on that table, because it has, trying to remember, 12 or 13. It was a way for you to pull that information together and kind of see it lined up in what could help you make some differential diagnoses or guidance with the primary care provider.
Right. And then I'm not sure if I remember correctly, but one of the interventions that we should do is notify all of the sexual counts.
Mm-hmm.
Yes.
Right? Okay.
Yes, and if you go to CDC or Texas.gov, it has the list of the reportable diseases, which all our STIs are there. It also talks about on that table how fast we should report, but the big treatment modality is contacting all the contacts, because that, you shake 2 hands and they shake 2 hands, and that exponential transmission. So we do need to track the contacts, get them tested, and start treatment with them.
Yeah.
Thank you, Ms.
And then using condoms would be another teaching.
Right. And that, all the other birth control methods do not protect against STIs. They are birth control only, except the barrier methods.
Correct. Good questions. Where does a stillborn fall and GTPAL? So, well, what do those stand for? It depends, of course, are we talking in term, baby? Okay, so stillborn is a birth, right? So we're talking, but you can have a premature birth, stillborn, or you can have a term birth. So that should tell you sort of where it starts. Gravida, if they were pregnant, then they were pregnant. That's a pregnancy. If that was a term birth, then they have a term birth as well, but no living children. So if it was just first baby, it'd be 11000.
And
Could also-
then, as Ms. John said, if it's a preterm, again, it would be 10100.
Right,
0.
same thing. Yeah,
So it depends on, was it term or preterm, and they fall into the living because they would not be a living child. So what are the interventions for that prolapse cord? Trendelenburg, and are you saying prolapse that we're identifying? Oh, the actual prolapse that you're feeling it. So yeah, Trendelenburg. Hold the baby's head off the presenting part. The presenting part, yes. Relieve pressure on the cord, yes.
true. Well, I think they got that one.
Right, and off to cesarean delivery.
It was just, I think on the exam, it was something about applying pressure, and I just will never forget it because I was shocked. It did something about applying pressure with a gauze, and I picked that one, but apparently it is wrong because it has to be a moist gauze. So I
It
just wanted
wasn't
to,
applying pressure, it was covering it with a sterile gauze. And is that going to, it should be moist to keep it from drying out. And I can't remember if that was a Selectol or the priority. If it's priority, what is the gauze going to do to provide oxygenation to your fetus or to your, nothing. So our concern is getting oxygen to the baby, not protecting the cord from infection or even drying out. We have to get the presenting part off the cord so the baby gets perfused.
Yes, absolutely. And I would know, along the same lines, I would know your differences between the previa and the abruption, the placenta. Remember, abruption's medical emergency. With once that abrupts, the baby has no lifeline. And you can also have the problem, the baby still in the uterus, and so we have pressure and you can not have all the blood even out. We can end up with a severe complication with mothers. So abruption's medical emergency. Previa, there's no pain, but they're having some bleeding off their feet. Get a hold of the doctor, but it's not, just feel the baby still moving. It's not an emergency. You need to get there. But if it's an abruption where there's severe pain, a lot of bleeding, you've got to get help.
Okay, and going back up to Jessica, something about, clarify what you're asking about variable D cells.
I believe that was Isabella's question, but I'm assuming
Okay.
we would. I don't know if Isabella can speak, but I was just bumping her question.
Okay, Isabella, do you want to expand on that question about variable D cells?
Oh no, I was just asking because I remember that question on the test of what was the priority intervention to do when we have a prolapse cord. I don't know why I put the variable. I know it's
Okay, because you can have an indication, variable D cells are an indication of cord compression, but it may not be a prolapse. It could be that the baby's head or a part of the baby is got cord between the baby and the uterine wall. So that's when we start. That would be our category 3 in fetal heart monitoring, that you want to reposition moms, increase her fluids, give them oxygen at 10 liters, stop the Pitocin to get the pressure from the cord relieved, and see if those interventions take care of it prior to doing anything more aggressive, such as a cesarean delivery.
okay.
So looking through those interventions for category 2 and 3 fetal tracings.
Thomas, do you have a question?
You want to take that, Ms. John, or you want me to?
You can tag on me. So the most important is whose life's at danger? My baby. So if my baby's not getting oxygen, so if it's a prolapse, I see the cord, got to get the pressure. I've got to get that baby up. I'll keep the pressure off that until I can get the baby delivered. If it's D cells that are variable, put oxygen on the mom. That means our baby gets oxygen. And then I'm going to try repositioning. Often it's, however the baby's moved or whatever part has jammed the cord against the wall of the uterus during a contraction. So it sort of depends on when they're variable and if they're recoverable. Is that a word? I hope so.
Okay, and usually we say if they have an oxytocin drip, we want to turn that off first as we're doing those other things to make sure we don't have a hypertonic contraction going on in the category 3s.
If we're going to relieve the pressure from the cord, it's better to do it with positioning because it's less invasive than inserting our hand first.
No, You need to keep your hand in there because positioning is not going to do it all. You have to,
Okay.
as that contraction starts again, that's going to overcome the Trendelenburg position. So you have to keep, and you're going to usually identify it with your vaginal exam, unless it's a Frank and it's laying on the bed. So once you do that vaginal exam and feel the cord, you keep your hand there and keep pressure on that baby's head while somebody's putting the bed in Trendelenburg. We're getting everything taken care of, and you keep your hand in place to keep. You're going to be pushing against that contraction to keep that baby's head off the cord.
Okay. Thank you.
Absolutely. Absolutely. And we're thinking, again, think your ABCs. If I don't do this, my baby doesn't have oxygen.
Okay, I have a question. I guess it's kind of following up on the variations. Under what exemplar does the variations fall under? Like monitoring the fetal heart rate. I'm trying to find the specific readings under Lippincott, but what exemplar does that fall under? Newborn care or?
It would be,
Labor.
yeah, it's labor and delivery procedures, but it should be under labor and delivery.
Yeah.
Electronic fetal monitoring.
And again, I wouldn't,
for Lippincott,
as I say, I
under
wouldn't
Lippincott,
try to memorize a table or anything. I would, if it's a question on that, we'll give you enough information that you can pick the correct answer. We're, like I said at the beginning, knowledge is good. We expect you to have that, but we want to see you apply it. So I would put my energies more into, if I have this, what would be my first interventions as what's my priority as a nurse?
right. But looking under the Lippincott, and there is some great interventions on there. But unfortunately, there is not a, if you will, labor and delivery exemplar. So I would also kind of like to make myself familiar with the variations and what they look like on
Okay.
paper, because that was the test question.
Jessica, this is Jessica talking.
Mm-hmm.
Okay, there you go. So if you go back into our course, under reproduction, there is an electronic fetal monitoring PowerPoint, and the references are on the last slide. So some of it is from A1, but I also cited where you are going to find it in your textbook.
Okay, perfect. Thank you.
Okay. And that also has sample strips and some explanation and how you do that fetal monitoring interpretation. So again, as Ms. John said, if more understand what's going on with those, review your veal chop so you understand what are the concerns, remembering that early are fine. It's those repetitive lates and variables that we're concerned about, and they're all kind of, if they're not category 1, which is normal, great, the baby's wonderful. Category 2 and 3 are intervened with the same way, because again, we're looking at oxygenation to our baby and what do we need to do about that to keep baby safe.
Yep. Good questions. Anything else on repro? What's our next concept, Ms. Hudson?
Repro, and I think it was interpersonal relations, and then sexuality. Then we went to cellular regulation. So that was our next exam.
Interpersonal would be in the psych, and I don't know what, that wasn't in the first unit. So maybe it's in the second.
I think it's something. Oh no, I'm sorry. I keep saying interpersonal, but it's human development, sexuality, and repro. But our next one would be now cellular reg. That would be the next big one.
Okay, any more questions on repro before we go to cellular reg? A list of medicines for reproduction. Can you be more specific? What you would like, Jasmine? Jasmine?
You should have all that in your clinical. Oh, I guess if you had, yeah.
Yes, in the The OB worksheets all have a list of medications you should be familiar with related to labor and delivery, NICU, prenatal, antepartum, postpartum. So the primary drugs are listed there.
Will you tell us that answer, Jackie? What's the first intervention with a boggy uterus?
Exactly.
Absolutely. You cannot have a boggy. You got to fix that. Yeah. First intervention. First thing you do is grab it. And it's and knead it like a roll of dough, bread dough. Good.
And
Nikki?
Magnesium sulfate, that can be used for both preterm labor and labor and delivery. And is that just to prevent a mother from going into eclampsia? Is that the same for both of them?
Mm-mm.
Yes.
Okay.
Preventing seizures. Absolutely. And we're not in eclampsia until we have seizures.
Right.
So
but
we're going
it's,
to
as I said, it's also used for preterm labor to slow down, to try to, because it's a smooth muscle relaxant. So
So that's why you know when they're toxic, because you lose your muscle reflexes. You lose that musculoskeletal response because it's a muscle relaxant, so we will use it. All right, I think if there's nothing else on repro, we can go back over to cellular regulation. Unless I missed something. I try to follow the chat, but
I think that was it.
okay.
I think Ms. Smith answered that and said that those are listed on the OB sheets. Am I correct, Ms. Smith?
those were the drugs.
Oh, the
The
drugs.
lab are looking at your H&H, recognizing anemia of pregnancy because of the dilutional factor going on. So looking at what are the actual labs for pregnancy for your H&H and WBC. The RH factor, Miss Johns, help me out. I always forget the GBS.
Yeah, for strep.
So the torch labs. So those would be my primary ones. Am I missing some, Miss John?
And then blood sugar.
Yes, glucose and dips
And
urine.
remember, your baby's a parasite. They're beautiful, wonderful, lovely parasites. I love them all, but they are parasites. So they're going to take from mom what they need. They have a innate desire to live. So that's why we watch mom for anemia. And usually in that 28th week, we'll be checking her sugar. We'll be checking her H&H to make sure that the baby's not taking more than mom has to supply and leaving our mother with problems. So, and some of the others, like the strep, GBS, we'll do later. RhoGAM we'll do early. Does that help? Okay. I think that's it, Miss Smith, isn't it? I think we got it between us two. Okay.
Someone has thyroid level. Kavita, what do you mean? Are you answering a question or asking a question?
Not necessarily. I mean, it's not one that just stands out because of pregnancy. Usually we don't see, sometimes we see it after the baby's born. Mom may have some dip in thyroid levels, but it's going to be part of the metabolic panel, so we'll pick it up. But it's not one that just sort of hits you in the face in pregnancy. It's not more significant there than it is for other populations.
Right, unless they have an underlying comorbidity that they already have a thyroid issue, then
Yes.
obviously we're going to monitor that, but it's not one of those that it's like we absolutely have to check this thyroid.
Yeah.
And yes, we always do that urinalysis, not usually in labor and delivery, but that's something that we check at each prenatal visit, is the urine, excuse me, and their weight is that thing that we do, vital signs, weight, fundal height, and urinalysis or a urine dipstick is something we do at every prenatal visit.
Okay.
Question about diabetic mom and insulin intake.
Okay, so are you asking about gestational diabetes or a mother who is already a diabetic on insulin? Two different things. Just want to know where to go with it. Okay, so let me ask you a question. Then I know you didn't think this was a question and answer where we could ask and you have to answer, but does the mother, because she's pregnant, have increased metabolic demands? Okay, so we're utilizing more glucose. So yes, there will be adjustments. Can we say that every month you increase by 2 units? No, we cannot say that. You might try, you might see things that say that it does not work that neatly, but she will have to monitor and possibly, most likely at some point, especially during the second trimester, make some adjustments. But there's no real neat formula that applies to all, but adjust, yes.
So, Ms. John, is it, sorry, Tom, is it specific to each patient for adjusting the insulin?
Mhm.
Okay.
Yes, with their provider. Yeah.
Right. And
Things
usually
that
the readings say, that they become more sensitive to insulin in their first trimester. So their insulin dose may decrease in the first trimester and then go up in the second and third. But as Ms. John said, it's very individual. They need to be monitoring that more closely as things are changing and that fetus is growing. With the gestational diabetics, that we're not going to identify that until after the 24th week when we do that GTT. And they're now using metformin as well. So again, that insulin is, or whatever medication they're on, is going to be adjusted based on how well they're controlling their glucose, their finger stick blood sugars during the remainder of the pregnancy.
And the only other thing from gestational diabetes, and that was last semester, is close monitoring of the baby, because just the fact that mother's been diagnosed with gestational diabetes, we may see some either retardation of growth or some increase in baby's size. So we may have a large size for gestational age. So we're going to do more frequent ultrasounds just to monitor the baby. I think that's it, isn't it, Ms. Smith?
I believe so.
Is the diet for gestational mom, diabetic mom, excuse me, is it, excuse me, is it a diet to increase carbohydrate, if I'm not mistaken, for all pregnant moms, including diabetics or non-diabetics, or is just for diabetic mom? Like, can you give us some information about the diet, which kind of diet they need to follow or increase during that stage?
Basically, they need to increase meet more metabolic needs. So they're going to have some increase in protein unless we're spilling it in the urine, going into preeclampsia. We need some increase in complex carbohydrates. But that's going to be across the pregnancy. If we make any adjustments because mother is diabetic, we're going to make it with her insulin, as long as she's maintaining a healthy diet and we have good weight control, weight gain, baby's looking good. And then the other thing, if we mother has gestational diabetes, then we may rearrange the diet. But that really, as a nurse, we're going to encourage our mom to watch her blood sugars, keep track of her weight, keep her appointments, and let her physician carry out the rest.
And then for their diet, remember they need about 300 more calories a day, and they need to be nutritionally dense calories, not those empty calories. So again, looking at, we're looking at carbohydrates. We want those complex carbohydrates and proteins and things that give them the nutrients that mom and that fetus needs for good growth and development, not sodas and whatever else that really are just calories without any nutrient value to them.
Thank you.
Thomas, that question, I may have to decrease my insulin in the first trimester and increase later in the pregnancy. I would say that would be a true statement because it says I may need to do these things if this is a pre-gestational diabetic.
Correct, Brittany.
Okay,
Yep.
this one, I guess we kind of go a little bit towards Ms. Smith, because I guess Ms. Johns, you kind of answered it a little bit, but I'm looking on human development. That's the concept for the exemplar in aging. But there was that very scary, very traumatic Tanner's picture, and I just wanted to know if that's what we were talking about, aging, like we said, Ms. Johns, in the entire lifespan in regards to human development. I know that I was kind of focusing on the geriatric side of it because I was confused on aging as in, you know, an older adult or aging across the lifespan. And I guess that's why the Tanner's picture kind of threw me off because I wasn't aware that it was aging from adolescent to, you know, teenager.
Well, in the human
Sense of
development where
sexuality.
that picture came in was more human development, and sexuality, what is the normal progression of sexual development. Aging itself was the older patients, was our more, as we get older, so what are those expected changes? So those are two, you know, you can look at it from two different perspectives. So what are those expected changes as we get older?
Right.
Which is what our presentation and thing talked about, so that we don't have those ageism stereotypes that we just don't say, well, that's because you're old.
Right.
So recognizing that, but the Tanner's picture actually came in for that human development and sexuality component. They kind of crossed over each other, that as you're assessing your patient or seeing your patient, what would you expect to see? And if you had an 18-year-old that was not at the appropriate level of sexual development when you're looking at their genitalia, you need to be familiar with what they should look like. So you can say you're behind, you know, did their hormones, that they didn't go, they're having late onset puberty, what's happening, or they're very advanced and they're having precocious puberty, that they're going into puberty at 9 or 10 years old. Is that appropriate genitalia? So having that understanding of what that is supposed to look like is where we were going with that.
Okay. Thank you.
Mm-hmm. Yes, flexion contractures. So we want to stretch out. The flexor muscles are stronger than extensor muscles. So Martin is correct. We want them prone a couple times a day to keep those muscles stretched out and keep that joint functional. So when they get their prostheses, they can be functional.
Next question.
No questions on cellular regulation. Michelle?
Yeah, when you say to know the primary medications or drugs for chemo, what do you mean by primary? Like the main ones, or because I mean there's a lot of
I
chemo
would
drugs.
say that. Were you talking, Miss Johns, or was that me? Or Miss
That's
Smith? Go ahead.
I think that was you. Go ahead. I thought, I don't know.
Yeah, I would learn more of the, what are the classes. That's the best way to, when you're looking at the chemo drugs that are, the classes is kind of what, it's going to vary between which cancer you have. So just understand if it's this class of drug, this is how it should respond, to answer your question about primary chemo drugs. I'm not sure who said primary chemo drugs, but.
Would you say also, Ms. Hudson, they probably ought to have some focus on the side effects?
Correct, and how those are going to impact the the patient. What side effects would you look for? So how would it affect their CBC levels? What are they more prone to because of receiving chemo? That would be the things that I would look at. So side effects. Common problems related to radiation and chemo that patients experience once they receive it. Kristen had her hand up.
Yes. When we're talking about B symptoms related to Hodgkin's and non-Hodgkin's, if they're asking what cancer you're talking about when you see these symptoms, is it going to be Hodgkin's or non? Because I know those were both options in one of the questions on the exam, and I wasn't sure which one to pick, and I never got to review that one. So
I believe that was also in that worksheet. Mrs. Smith, correct me if I'm wrong, because I think that worksheet's already filled out exactly where the B symptoms are. And would I be incorrect?
And the B symptoms are for Hodgkin's and non-Hodgkin's. So those B symptoms cross into both of them.
It's just more of knowing what B symptoms are. I think that question didn't ask which Hodgkin's it was. I think the question asked what were the B symptoms, or what were those classes, the symptoms the patient was experiencing. What were they?
okay, thanks.
Ms. Smith?
Yes.
Or Ms. Hudson, either one. Talking about the B symptoms, I believe there was A and B, and A means that they're usually asymptomatic, and B means that the symptoms are severe, correct? Or it's like worsening.
No, there's nothing that we call A symptoms. B symptoms are that they've had a weight loss. They're running temperatures, especially at night.
Drenching and perspiration, trying to think
Right.
of them.
And wasn't
they're
weight
gonna be
loss greater than 10% of their
10%, yeah.
Yes.
So on the sheet, I believe I have B symptoms, and then I have them listed in the table what those B symptoms are. And A doesn't mean asymptomatic. We just call them B symptoms and if they present and they already have B symptoms, their outcomes are not as good.
Okay, thank you.
And basically you're looking at that being applicable to all lymphomas as opposed to leukemias. So,
Okay,
but
thank
all
you.
lymphomas.
So if it asks the patient presents with fever, night sweats, and weight loss, what cancer could you expect? Would you say Hodgkin's or non-Hodgkin's?
Either one.
I think you need more information to the question.
Yeah.
So if
Could be
it was
TB.
designed to go to non-Hodgkin's, then there would be other signs and symptoms that would be related to non-Hodgkin's. If the design of the question is to go to Hodgkin's, then there would be more signs and symptoms related to Hodgkin's. Does that make sense? So it'd be more than just the symptoms. So there would be other factors that would be a part of that stem. So that way you're not, this should be for Hodgkin's, or this should be for non-Hodgkin's. Does that make sense?
Yes. Thank you.
And
Or
then
as
the way,
John said, it might be a question that would you be anticipating leukemia or lymphoma? So with the B symptoms, it would be the lymphoma.
Okay.
There, and the first symptoms you gave me, my first thought was TB. So the question will give you a little more information. Okay, Kristen, did you still have a question, or?
No, I just need to put my hand down. Sorry.
That's okay.
So I think the next question, someone answered the one about the breast cancer location. Since I'll answer the question about the right way to do the breast exam. According to the American Cancer Society, it's the vertical pattern. So you can still do circular motion, but the pattern for which that is done is not around the boob. It's from the top of near the collarbone down past and up. So that way you get more breast coverage.
No.
Does that answer your question, Lauren? Okay. I think this is going to be from Ms. Gordon about behaviors related to ADHD patients.
I think that may have been in human development. Wasn't that?
It is. So what are those behaviors that we see in this child with ADHD or ADD?
Hyper what?
Impulsivity, yes.
Yep. There you go.
Okay.
There you go. Mm-hmm.
Trouble focusing, excellent. Hyperactivity, action. Okay.
Remember, it has to be observed in more than one setting.
Correct.
And before, I think the guidelines for ADHD are
Is before age 12.
6, isn't it?
Say that again, Miss John.
Isn't it before the age of 6?
I thought it was before the age of 12. We'll have to go back and check
Maybe it's
that.
between 6. Yeah, I didn't teach that this semester, so I know 6 in there somewhere. But I will see if I can find that for you. But I know it has to be more than one setting.
Right, more than one study. Six items in 2 settings. We're going to check on the age.
Okay.
So hyperactivity, loss of focus, impulsivity, scattered conversation. As when we were doing it in class, all of you have seen Up. So, all those dogs and there goes the squirrel. That's our hyperactive child. This easily distracted. And what do you want to do as far as your interventions for ADHD?
Symptoms usually merge. Signs must be present at least 6 months, have occurred before the age of 7. That's where I was getting 6 months before the age of 7, and present in 2 or more settings.
Thank you, Miss John. I was getting ready to look that up.
All right.
It's one task at a time, simple instructions, maintain safety, and consistency. Excellent, Jessica. Consistency is very important. Yeah.
And the other one big thing for ADHD is positive reinforcement, because they get a lot of negative reinforcement.
Yes, I was just getting ready to say that as well. So reward those good behaviors.
Rectal prostate exam.
Okay, what are you asking as far as the prostate exam?
How rectal prostate exam.
We want to do that we want the PSA prior to a rectal exam, because massaging the prostate can release more PSA and give us a false positive. So blood work before the prostate exam. If they do the prostate exam, they need to come back to get the blood work done a couple of days later.
And even a positive has to be monitored. It's not a specific.
Right.
And I think most of them are adenocarcinomas, prostates, I think, yeah. Solid tumor. Droppers, yes, okay. For stomatitis.
As far as I know, we do not do the hydrogen peroxide. It's an oxidizing reaction.
Yeah, I don't think
So
so.
that could be damaging to tissue. Can you tell us where your conflicting things are in the text, Danielle? No alcohol mouthwash.
I
Right.
can't remember where exactly I saw it in the text. I think it was conflicting between PrepU and the textbook, but I can't remember. I had wrote it down as a question before that test, and I just saw it again.
Okay. Let me see if I can find it in here.
Find it. And are you talking with cancer patients, right?
Yes, ma'am, with cancer patients.
They usually use that biotine
Mm-hmm.
for that.
I know we've always done baking soda and water mix, or the Mylant. I don't. Well, I haven't.
And sometimes with some lidocaine in it to
Mhm.
decrease the pain.
The pain, yeah. I don't not remember knowing anything about doing peroxide, but
Right.
I know nothing with alcohol because it will dry it. We'll have to look because I do not know anything on the hydrogen peroxide. Do you, Ms. Hudson?
No, they usually use things like biotine, which is, to help with that.
Yeah.
Not anything that's going to burn the mouth further.
That's what I'm thinking.
So like cool, like topical corticosteroids, antibiotics, anesthetics, those are things that they would use. Jessica, I would actually understand the types of anesthetics that would be used, that there are different types, again, classifications, and under which conditions, because there is kind of an option. So it's going to depend on, what the patient wants, and then where are they in the stage of labor and what they can get. Would that be correct, ladies?
Yes, and usually it's an epidural or a spinal, and really looking at what are those things we need to be monitoring for, and what are the interventions. So what's that most common side effect of, especially an epidural?
I believe we get hypotension. I think there might have been a question about that on exam 2. I didn't get to review it, unfortunately. But we would give a bolus normal saline, wouldn't we? Or
Correct.
some kind of
Yeah.
isotonic solution? Okay.
And
Yes, Nikki.
Okay, so for the epidural, we gave the bolus of IV saline solution before, but they still go into hypotension. Do we reposition them, like in the, was it the lateral position, if that were to occur, or is there some other measure we do?
You do want to reposition them, but we need to put their head down, and they still, it's from vasodilatation. So we need to get that blood pressure back up. So they may get boluses throughout that laboring process. Because remember, they're not taking in very much fluid. They're not taking any PO fluids, right? They're working hard. So can they still be, can get into that fluid imbalance. So, and with the vasodilatation of the epidural, they can continue to drop their blood pressure. And what is our big concern with that hypotension is, who are we concerned about, mom or baby?
We're concerned about the baby.
Yeah.
Right, because that low blood pressure is going to do what is impacted for the baby. What concept? Yes, perfusion, which carries their oxygenation. So we need to get that blood pressure back up so that uterus and placenta is perfused adequately. Even if mom is feeling fine, she's not dizzy, she's not diaphoretic, she's not nauseated, we still have that drop in, that decreased blood pressure, and we've got to get it back up. And the only way to do it is going to be with those fluids. Laying her down, repositioning her will help get better perfusion to the uterus, but the blood pressure still has to get up adequately to get everything else taken care of.
And we may be limited in our ability to reposition because of the epidural. So we have to think about that too. But your priority assessment is that blood pressure. It really is, and it changes very quickly. And the only other thing I would say on drugs used in labor, if we do use any kind of narcotic, hopefully we're not anticipating a sudden birth, but that would be something. How far along are we before we don't want to use it with deliveries imminent because we're going to have a baby with the effects of the narcotics. So you've got to think about things like that when you're giving them. Can't think of anything else offhand. Do we have anything else on cellular regulation? They're quiet, Miss Hudson.
Okay. I'm going to have to check back out. I have to go back to clinical. So
okay.
Good luck on y'all's exam.
All right, Eunice, what's your question?
On the exam for cellular regulation, there was a question about platinum drugs, but there wasn't anything like that covered in the textbook because I went into the pharmacology book. Can somebody cover that and specify where they would be classified under the new classification in the textbook?
I believe there's a table of all of the in cellular reg. Let me find it real quick and we'll move on to the next question.
Okay, question about autistic. Letting them play with this light switch. Okay, I'm not sure what you're asking, Marissa. Were we trying to redirect the autistic child? That's usually what we're trying to do.
So the question was just saying, what would you see in a child, an autistic child? And the answers had to do with behaviors. So it didn't give us an option on what would we want to do to prevent this child from doing repetitive behaviors. It was just trying to, ask what we would see. So I don't know if I got that question correct because we never got to review that part of the test or those specific questions. But I don't know what exactly we were supposed to be looking for because I could see how each question, how each answer it was worded, it could have been something an autistic child would be doing. So I didn't really grasp that question very well at all. If anybody remembers the question.
Okay, so I'm seeing more of the question. Yeah, okay, so then when they don't respond in an anticipated way, I see what we're asking. Okay, so that would be an abnormal response to, let's get a snack. I'm going for that.
Okay, I think I maybe got that question right, but not because I knew the reason why. I think because I guessed, because I didn't see that on my review with Miss AB before we started this.
Okay, ADHD is part of human development. Mm-hmm. Anything else? Nothing else on, where were we, Ms. Hudson? Cellular regulation?
Cellular reg, and then there should be mobility and comfort would be the next. So your the concepts there were ICU, procedural pain, intubated patients. Oh, wait a minute. I went the wrong place.
Neonatal pain, I think, is there.
Yeah, neonatal pain, cancer pain, chest tube, RA, then all of the trauma, fractures, and musculoskeletal injuries, neuropathic pain, and amputation. That was comfort.
Okay.
And mobility looked at cerebral palsy, spinal cord injury, and then again, all of the musculoskeletal traumas.
Okay.
I have a question. Maybe Ms. Hudson can answer this. Ms. Hudson, in class, you went over the insertion of a chest tube, and you said that it was between which intercostal space, if it was in the emergency room, and then there was another one where it was not in the emergency room. I think there was an answer choice on that. If anyone else saw it?
So if you, in the emergency room, they're going to do a lateral chest tube, which will be your 4th to 5th intercostal space mid-axillary. And usually pre-hospital, it's the 2nd or 3rd intercostal space mid-clavicular.
Thank you.
So in a larger patient, they will do lateral pre-hospital. So they have the option to do either the more anterior chest or the lateral, which would be mid-axillary. But at the hospital, they're going to do the lateral chest tube, which would be the 4th or 5th intercostal space. Does that answer your question there?
Yes, thank you.
Okay.
Oh, I have one more question, sorry. This question, it was talking about a patient with RA. Would you recommend them to rest their joints after they just took a warm bath, or would you promote them to continue moving so that it doesn't cause spasticity or stiffness?
A warm bath actually helps to loosen the joints or make them less painful,
right? So
that they can move. But
right. So you wouldn't want them to like stop, right? Since they're already moving, they've already put oil on that, so movement. Okay.
Yeah. We want them to move to try to prevent some of those contractures as well, and to be able to care for themselves, but not with pain.
Splinting would be more for the fingers, and to kind of help them not contract. Right. So that would be more. That's another option that can be used. But if they're already up and they're showering, then help me. This was your question, correct, Jessica? She's basically asking, should they continue to move or stop? And so after they're loose, then you would be moving.
Yep. And then there's a question about neonatal pain compared to adults. So neonates have pain, experience it exactly the same way as adults. There's no real difference as far as whether or not they're having pain. So, what was your question specifically?
Are you looking at how do you tell if they're having pain, or
Okay.
what
we give them?
scale would you use? What would you do?
I think it was like a question that said like comparing. I think they're gonna have like a procedure, and how would you compare their pain to an adult?
Okay, so it's the same pain. I mean, they experience pain the exact same way. They can't obviously verbalize pain, but we get cues from. They do not have a lower pain tolerance. They are pain to the neonate is the same as it is for the adult. We do know that repeated pain exposure, like through procedures and interventions that we have to do for a newborn, especially a preemie, leads to heightened awareness of pain later. So they respond, don't tolerate as well because they've been exposed to it earlier. We do know that from research, but as far as the pain, they have the exact same pain sensory, I guess you would say, as an adult does. They can't express it, so we have to observe, use the flex scale or something that tells us, or the NIPS scale, so we know what things to observe that tell us our baby's having pain. They got their eyes shut and they're tense, they're hurting.
Or the brow.
The brow, yeah, huh? Furrow. Yeah. Nikki?
I just have a question regarding that RA question that was asked. During our test review, Ms. Johns, you said that, because I think that was a test question, it was a select all that apply. One of the answer choices was a warm shower and you rest after, like a rest period after. And I had just a specific question about that, because you said it wasn't going to be like a real rest, but like smaller activities. So that's why I'm kind of confused with how that one was.
No, so if they're active, if they're getting a shower and their joints are warm and relaxed, that's the time to move. But they don't keep going, I guess, where I was trying to go with that. So once they're beginning to feel some pain, discomfort, they need to rest. But it does give them an opportunity to do some of those, their shower, maybe do a couple things in the house or get a meal or whatever, and then a rest.
So having a warm shower and then resting would not be an answer for what a person with rheumatoid arthritis should do, right?
You'd have to give me more in the question, I guess. I don't, but if they've been active, they've been doing something and they were having some pain, they took a shower and then needed to rest. If that was their relief of the pain, then they would rest. So I guess it would depend on what the question asked. Sorry. I guess I don't know the specific ones. So. If you have anything else on that, Ms. Hudson, but that's how, I mean, once they're warm, you want them to do what they can, but if they've been doing and they're hurting and they're taking the shower to get some relief, then yes, they would follow with rest.
I think the bigger understanding is what do they need to do? So it depends on what the stem of the question was asking.
Right.
So if the person had already had, they were already doing activity and they were having sore joints and they decided to take a shower, then, rest would be the appropriate thing after. If it's, getting up in the morning and their joints are stiff and they take a shower, then movement would be the answer there. So I think it depends on what the stem of the question is asking. You guys are remembering specific answers, but I think in the grand scheme of things is, what would be the appropriate treatment for what the patient is experiencing versus, we're going to do this for this one here and do this. It's for all folks or for all situations. So, same thing with, I think someone was asking about whether we use heat or cold. It depends on the situation, which one you would use. Usually the first 24, 48 hours, you would be using, cold to help with inflammation and things of that nature. Then after that 48 hours, then you can alternate between cold and heat. Those are all options. You can also use a TENS unit. Some people find relief, some people do not find relief. So I think in getting the understanding, these are tools that you can use, or tools that the patient, or interventions instead of tools that the patient can receive related to the particular situation. So, my focus would be, if I have this patient, what do I need to do? So if I have somebody with a stump, can I put lotion on it? Can I massage it? Should I elevate it? Should I have them prone? What's the purpose of that? Why are we doing these measures? And what I'm seeing here, you guys are going back to questions that you may have missed on the test. And I know you're trying to get the understanding, but I would be trying to understand the whole component of it, if that makes sense, not just the one specific pieces. So.
Right, and then heat does, of course, dilate, so it does cause some vasodilation, and cold constricts. So, and I think it was probably my second level class, but yeah, I asked and this has been a long time ago, but I asked an orthopedic surgeon one time, because we were having a discussion on the unit, should they have cold, should they have hot? How long do you tell them? How much in between? Can they alternate? And I asked him, I said, what's your advice on this? And he said, what makes the patient feel better? I said, oh. And he said, really? He said, we know at the beginning, if we have a lot of swelling, we want to put ice for vasoconstriction. We want to constrict and compress. But he said, if you put ice on a day later and they say, get that off, that's just throbbing, get it off. And they said, let me try heat. And they go, that feels better. Go with it. So I took that advice.
I think there's options depending on where the patient is in their recovery as to which one you would use. But usually right after surgery, they're going to come out with an ice bag already on. So just, understanding how often they would need to do this for, and monitor based on how the patient is feeling, if the swelling's going down. So I think there's a question on the table. So for testing purposes for RA, use heat to get things moving, and cold for pain from overuse. If they have swelling, Thomas, then that would make more sense to use the ice or cold.
Always going to suggest rest when there's pain present.
Say that again.
We always suggest rest when there's pain present, whether it's after a shock. Okay.
Correct. So we're not asking patients to push through. We're trying to educate them on, although this may seem like that there's a lot of flip-flopping, what's really happening is you're paying attention to what your body is saying. So if your body is saying, okay, we've been used too much, then we need to stop the activity. So we're not going to keep telling them to push through and all of that. We need to stop and get some rest and let our joints rest. So if we wake up and we are stiff, then our body is saying, okay, these joints are stiff and we need to use something to loosen these joints. And then we're going to keep on moving after that process. So I think from that standpoint is how you should kind of maneuver through, whether you're going to use heat or whether you're going to use cold. Now, the question may have asked that, what interventions would be a part of the care? Now, that could be, any of those things could be possible that would be applicable in helping the management of those symptoms. Does that make sense? Versus, something very pinpoint specific. So it depends on what the question is actually asking you. So if it's saying which of the following would be a part of the patient's care, then hey, they could use a TENS unit. Hey, they could use heat. They could use cold. But if they have a negative to the cold, so use cold when when joints are stiff. Does that make sense? Now, would you do that? No. So then that answer, although cold would be correct, but it would not be correct for when joints are stiff. Does that make sense?
Okay.
So it's knowing when to apply those principles. That's more of the question. When do I utilize these things? So in order for the answer to be right, but all pieces have to be right. So if there's one piece in it that's incorrect, then it's all incorrect. Even if the other 2 or 3 pieces that was in it was right. So hopefully that clears that piece up. There's something else I wanted to add to that.
Yeah, something on the.
I'm still trying to find that chart. I actually found the stomatitis question, which was funny. It's like, that's not what I'm looking for.
Another question?
Yes. I think we had talked about this previously on our, I believe it was before a couple of lectures previously. We talked about anaphylaxis, and I think Ms. Hudson, you said if there's nothing wrong with the oxygen, with the O2 stat level, you don't give oxygen, you move on to what is needed next in an anaphylactic shock reaction, correct? Which would be.
Okay, so let me clarify. Very quickly. Not that airway is not an issue, but airway is an issue because we have histamines that are being released in the body, and we need to stop that.
Right.
So I'm not saying you're not going to give oxygen. I'm saying that your priority is to stop the causative problem, and then you're going to treat everything else. So I know following Maslow's hierarchy, we would be looking at physiological needs. But in the process of an anaphylactic shock or anaphylaxis, we need to treat that piece first with the epinephrine. And then we're going to follow up with, our oxygen, making sure the patient can breathe, making sure we give all of the H1, H2 blockers to help eliminate any other histamine release in any other area of the body. And then once we address that, we still need to address inflammation. So they need to get some type of corticosteroid.
Okay, perfect. So then I guess in anaphylaxis, you're really just kind of trying to do first what would eliminate, if you will, the reaction.
Right. It's just no different than if a person got burned. Okay, you need to stop the burning process.
Right.
And then you start looking at all of those other pieces. So if you have somebody in an anaphylactic that's having anaphylaxis, then you need to treat that piece. It doesn't mean that you're not going to treat airway, breathing, and circulation, because you are.
Right.
But right now, I can treat all that, but my reaction is still going.
Right.
So what are we doing to treat the reaction part? Does that make sense?
Yes, it does. Thank you so much.
Okay. Yes, Thomas. Give Effie, not prepared. I'm not sure who said that, so I can't attest to that piece. Okay. I can understand why you chose oxygen with that information now. I get it, but I guess that's more of a semantics process, because you would be preparing it before you gave it. You could do that, but your reaction hasn't stopped and it's continued. So, you know, you have epi and a crash cart. So if we're going to go real time with it, so if this is in an emergency room and your patient comes in, you would be preparing that epinephrine, and more than likely the oxygen would have already been on the individual if they were coming in from EMS. If they weren't coming in from EMS and they were a walk into the emergency department, then somebody would still be getting, those two things would be happening simultaneously, but to fix the anaphylaxis, it would not be oxygen.
And yes, on the H2 antagonist to decrease inflammation. Jocelyn, you asked, do you always probably isn't what we use most often in nursing or medicine because it's different, but it is something that we would consider, both the H2 antagonist and an antihistamine post anaphylaxis, just to maintain and decrease the inflammatory process.
I think with the question asked, what are the following or something like that, which would be a part of the care, the treatment of the person with anaphylaxis. I think that would be inclusive. So that goes back to what I said before when you're looking at the heat and the cold. So if it's asking what will be a part of the plan or what interventions would you expect to do, then all of those things would be applicable. Now, if it says always give something, then more than likely, if that may not be the right answer with the always in front of it. So if there's one position for which that would not be done, then that always is already knocked out. Does that make sense? So I think.
Thank you.
So I think it just depends. Again, if it's, and this is why I'm, read the question. Yeah. And if it's asking if it's going to be a part of the interventions, then that would be all the pieces that would be applicable. So that whether it's an H1 or H2 blocker.
Right. Good.
I'm backing up because I think there was a couple of questions. I think Rodolphin, can you explain, what do you mean not residual in food? Are you meaning residue, or what do you mean? And then Fontana, you have your hand up.
I just have a simple question. If in emergency situation, if a patient has allergic reaction, of course we're gonna stop the medication, whatever is causing it. But if the patient doesn't have orders for oxygen, do we wait for the doctor to give the order and then get oxygen, or just go ahead and do the next step?
Most hospitals already have standing orders of what you would be able to do. So again, this would, you don't need to, that's part of your nursing care, applying oxygen to a patient so you don't let them go without. But I think you guys are getting hung up on how do we treat it? How do we treat a particular problem? And so if I have anaphylaxis, the first thing, it would be like if I wasn't in the emergency room and I was a patient and I was allergic to bees and I just got stung by a bee, the first thing I'm going to do is give myself epinephrine and or take some Benadryl, an antihistamine. So I'm not saying that oxygen would not be a part of the care, but the first piece here would be they need this epinephrine to be given. That is the treatment for, that is your treatment for anaphylaxis.
Okay, thank you.
Thank you. There was Rodolphine, do you mind? Non-residual diet for who?
It was inflammatory bowel disease, the type of diet and type of food included in that diet. Low residue, sorry.
Okay, you're talking about a low residue diet. So this would be a first and second semester or bridge concept. So that would be like your white rices, white breads, refined cereals and pastas, vegetables that are cooked really well without seeds, or, you know, take the skin off. Do you mean ulcerative colitis? Okay. Okay. That's a CT scan. So, does that answer your question? Okay. Next question. I don't have a problem doing a Q&A over that for those questions that were highly missed. I'm not going to go over it'll be just like I did it the last time. So this was a highly missed concept. So what is the answers to it? And, you know, folks will probably tell me what they chose, and I will tell you why that wouldn't be the right answer. So I don't have a problem with that. But this Q&A was for, you know, what are your questions about the material in preparation for your comprehensive. So I don't have a problem doing a separate Q&A. What day and time would work for you? This is too fun. So you're the class spokesperson?
You do a good job.
Yes, yes. Yes, Louina.
So I was trying to remember what we went over in that one question about the ranitidine for anaphylaxis. I remembered that, so I kind of Googled it, and then it said ranitidine has been recalled this month.
I mean, that question didn't have ranitidine. It actually had famotidine.
Oh, okay. So I thought it was ranitidine.
No, it was famotidine.
Famotidine. Oh, okay.
Yeah.
Next question, I think, was that Randy? No, that wouldn't be used for that. Not Montelukis.
No, that's a look at Jones. Right.
Thank you, Randy.
Ms. Hudson.
Yes, babe.
So I was reading, let me go back in these messages, UA. Okay, I was reading a kind of a little bit bouncing off of what I believe Martin originally asked about your ulcerative colitis and CT scan. So I have here that a barium study is a conclusive test for, I can't even read my notes. First, I believe it might be something off of IBD, but I don't know if it would be ulcerative colitis or Crohn's, because I have it's a conclusive test because it shows the string sign.
Mm-hmm.
So I'm like, And then okay, never mind. I think I answered it. A CT scan is more sensitive.
Yes.
Okay. Never mind. I answered my own question. Thanks.
So you gonna second that? It is a CT scan.
Okay, thanks.
So Lauren, are you asking what is the appropriate test for Crohn's? Or
Yes,
were
I'm
you
just
saying-
I'm just confused on it a little bit. Would it still be CT? No, it wouldn't, right?
No. For Crohn's, it's a different test.
Okay. And what test is that? Is it the colonoscopy? Or is it the barium swallow? Or the barium, yeah.
I believe that one would be a colonoscopy for Crohn's.
Okay. Thank you.
Mm-hmm. And a poop test. The poop, what do you mean by poop test? Mail-in poop? Are you asking for them to check for the bacteria or tissue? What? The consistency, the markers. Okay. It depends on the IBD. Are you just saying irritable bowel? Are you, it depends on what they're looking for. Fecal, okay. If they could do an OMP, ovarian parasite, they could use that in UC because they can have bacteria. So that would be helpful. Just if you're checking an occult blood, that could be used for several pieces. So not just UC, not that there's bleeding. So it's checking for bleeding, but it wouldn't necessarily say, well, it's bleeding because it's ulcerative colitis. Does that make sense? That bleeding could be, it'll be differential, but that bleeding could also be related to that. It could be related to diverticulitis. It could be related to a GI bleed. So the blood part could be many factors. So if you're getting a stool sample, then you're looking at, do they have any parasites, bacteria in it, and looking for markers. So, but if you're trying to, that would be part of your diagnostic studies to hone in where you're going. How detailed into psych meds? I think for psych meds, you just need to understand which ones you would use for which conditions. But I believe Ms. Gordon's here to help facilitate this discussion.
Yes, that is true. The common meds for depression, your SSRIs, and then bipolar, of course, the anticonvulsants, but lithium being number one. So understanding all of the nursing implications of giving the med correctly and teaching your patient to take it correctly. Looking out for toxicity, teaching the family all of that, and etc. So those are the common ones for this particular unit, just managing depression, managing the manic side of bipolar, and just picking up on the side effects basically of the drugs.
Ms. Gordon, I have a question.
Recorded. I don't know if it's been recorded, Alexei.
Ms. Gordon, this is Jessica. I have a really quick question for you. In regards to postpartum depression, are there any specific, I was reading that there's some, I just really can't remember off the top of my head, medications that breastfeeding moms are not allowed to take? Is that
Um,
maybe?
Yes. Lithium is usually not recommended for pregnant moms, particularly, of course, like many other meds in the first trimester. But I guess if they have to use them later in the trimester, if the situation is really bad, but they try to avoid it at all costs. The SSRIs, I cannot remember right off the top of my head, but they would use them gingerly, of course, in the first trimesters, like anything else.
All right, thank you.
I do know that according to in pregnancy, the SSRIs are considered safe, especially like Zoloft is one of the safe ones. I do know that.
Okay.
Because that's the one we often recommend they switch to if they're on something else.
Okay. Good.
Next question. Test complications with management. For which condition? It depends on the situation. And so if you gave somebody too much fluid, what would that do? There's a couple things. So when we give someone IV fluids, what is it designed to do? I mean, any of you guys can answer that. So basically volume. So it's designed to hydrate an individual. So we can cause we can cause overload. If we give too much IV fluids, we can end up causing electrolyte imbalances. So those are things that can happen when you give someone, overhydrate somebody, especially a pediatric patient. So theirs is going to be based on their weight in kilograms. But we use it to replace, like if they have a sodium loss, yes, we can use that. We could use lactated ringers to help with increase in potassium, because there's potassium in there as well. But it's really for volume replacement. But if you give them too much, you can actually end up turning their blood more of a pink color. So that would be a complication that the patient would have. And then you need to look at the patient and see, is this something that the patient actually needs?
And I think with fluid, anytime you're using fluid, you need to be assessing the patient. Some will respond quickly and others take a little more fluid. So you need to know, are you hearing things in the lungs you don't want to hear? Maybe we're giving a little too much or giving it too quickly. How's the patient responding? So it comes back to the nurse assessing the effects of the intervention.
So a good mnemonic, if you want to make a mnemonic out of it, is AIR, AIR, assess, intervene, reassess.
Absolutely. Thank you.
So anytime you do you assess somebody, you do an intervention, then you're going to assess and see, did this work, did this not work? You know, if you have a patient that you're giving a medication to and you're expecting pain relief, or you're expecting, the patient not to have seizures, then you need to go back and reassess that and say, hey, did this happen? Did this not happen? So did you get the desired effect? Yay or nay? So that would be more of, the focus there. Did the patient have the intended outcome that you were expecting? And that would be more of the question, or the answer to the question.
Mm-hmm.
Next question. No?
Miss Hudson?
Yeah.
You very, very brief, maybe probably in like the most simplest terms for me, really kind of explain the concept of interpersonal relationships in regards to the exemplars that it had with aging, disability of the family member, and expanding the family. I'm just interpersonal relationships in what aspect, like of the multidisciplinary healthcare team, or like the family dynamics? Because I kind of understood the exemplars, but I'm not too sure specifically about the concept, like what am I supposed to kind of get out of it, if that makes sense.
All right. So when you do that one, actually, that would actually have been
Miss Gordon.
Miss Gordon.
Yes. Okay. I will talk about that. Yes. So we are really relating to the fact of aging and the blended families and all of that. Just talking about the relationships. Interpersonal relationships is having to do with interaction, a social interaction between two or more people. So how, as the person is aging, how they're making an adjustment or transition to the family, if the family needs to bring them in, or if they're having to move to a nursing home, or finances, or some transition that they're needing to make in life. How do we help them adjust to that? We've talked about adjustment with several of your other exemplars, and sometimes as nurses we have to help the family adjust to whatever is going on. So, if the family is having to help take care of the grandmother, great-grandmother, whomever, a new child, new baby, adopted child, it's all about the family just transitioning to work this thing out because it's all new, and how we just adjust to this new situation, basically, if you will. Does that help a little bit, Jessica?
Yes, it does.
Okay. Because I know you guys didn't have very much reading on that either. So you had to kind of go back to your fundamentals book, and there's a little bit in Bruner's on the family and etc. But it's just about adjusting, interpersonal relating to these different situations.
Thank you, Ms. Gordon.
Yeah. A 100. Next one. No, someone asked how many questions was on the exam, and I said 100. Okay, you're welcome. $11. You mean how many times? Oh, 2 hours. Yeah. 100 questions, 2 hours. It starts at 11. Yes. I think that someone wanted to hold that till the end. So I think I just need to know a date and a time that you all were looking at that. Yeah, you guys are almost done. Saturday.
Ms. Hudson, is it 2 hours or 2.5 hours? Because mine is 2.5 for second.
I'll look. It may be 2.5, but I know it's at least 2.
Yeah.
Get those recorded. Which part recorded? Oh. There was a question. Those that have clinicals on Mondays, your final will be on Tuesday. That is true. Same time like you've been taking your other Tuesday test. No. So for you, what do you mean? I'm sorry. I think I'm getting lost and there's like different times coming. If you're in the Tuesday group, if you're in the Monday clinical group, your exams have always been on Tuesdays at 9. 25%. This is for the comprehensive. Should we submit for the retake if we are passing the class now? Yes. So very good question, Luina. I would submit the retake form because you can always withdraw it. So you can't submit it. So say for instance, after the comprehensive, if you're not passing, then that's the end of it. So you can't you can't submit the retake form. So according to our policies, all retake forms have to be submitted after exam 4 grades posted. So your grades posted about 1:15, but I actually gave you an extra 15 minutes and said that you don't, the last time or the due date time is Friday at 1:30. So if I don't have anything after Friday 1:30, or Miss Johns for Methodist group doesn't have anything after 1, if you send it after 1:30, I'm just going to tell you it's going to be too late. So can we all take our test on Tuesday? No, you cannot. Sorry about that, Rebecca. When will comprehensive grades be posted? So Miss Johns and I will get together, and Miss Smith and Miss Gordon, and we will, discuss if we have any issues and try to post those grades that day. Could pull us below, because the comprehensive, if we do badly, could pull us lower even if we're passing now. That is true. So the key is more for your safety. So go ahead and submit it now, Luina, and then you can resend it. So when you resend it, just send me an information and say that, I would like to resend my retest form for exam XYZ, because I'm going to be making a grid on how many people are taking, the exam 1, 2, 3, or 4, and then what your names are. So then I can just remove your name from the list. Should I submit the form to you? If you are ECC, and I posted an announcement, so each announcement is different. So read your announcements. If you're from Methodist group, then you're going to give it to Mrs. Johns. and everybody else would submit it to me. Where is the form for the regular makeup exam? There is no form. Your name is already on the makeup list. So, you know, we'll go through the grade book and see who has not taken a test already. So there's no form for that. Correct. At Tommy, it is in community under forms. Yeah, he's asking if there is no form, just for clarification, Jessica and Thomas, there isn't a form if you missed a test and you didn't take a test already, say you didn't take exam 2, there is no test to say, there's no form, I'm sorry. There's no form that says I'm going to take a makeup. If you take a test and you want to retake it, that's what that is. It's a retake form. So you can't retake something you haven't already taken. So folks that haven't written for the exam, you're already on the makeup list. So does that make sense? So if we have taken all the tests, there's not a regular makeup. It's just a no questions. That is correct. So if you have written for all exams and say, for instance, exam 3 was your lowest score and you want to retake exam 3 over, then you can take exam 3 over. Now I want to make sure that everyone understands that the last grade is what's counted in the grade book. So if your score is lower than the score you got before, that lower score goes in the grade book. It's not the higher of the 2 scores. How long do we have to withdraw? You have 24 hours after the comprehensive. And due to the fact that we have some Tuesday people testing, we may have to look at how these exams are going to play out throughout the day. So I'll be dialoguing with Miss McTan and with Chris Diaz, because that test would actually jump off on Wednesday morning at 8 o'clock, that was the time slot that was given. But since it's online, I think we can have a little bit more flexibility in those time frames. It's just going to be a matter of also coordinating with Mrs. Johns, because it can get very convoluted very quickly. So I don't know what time frame you have, Ms. Johns, do you know? For your second levels?
Resending to me.
No, the time that you have received from the testing center for your makeup.
Yes, I have Thursday and Friday, because I have students and clinicals each of those days, and my time is 8 a.m. Thursday and Friday.
Okay, so I will dialogue with them tomorrow just to get some better clarification to allow for, fairness across the board. Could you repeat just because
Did you have a date that you?
Yeah, I have a date of Wednesday right now at 8 o'clock, but I have some people that won't fall into the 24-hour realm because they're taking their comprehensive on Tuesday, because Monday they're in clinical.
Right, all of May are taking their comprehensive on Tuesday. So.
Okay. Yeah. All right. So how long do we have? Well, you have 24 hours. And then Thomas, could you repeat which part? You have 24 hours. When is the deadline to rescind? So the deadline to rescind will be 24 hours after the comprehensive grades post. Right, because you don't know whether you passed or not until the grades post. So that's why it's imperative for us to put the grades in on that Monday, so that you have that 24-hour time frame, and then you can rescind. Should we always retake the exam we have the lowest score? Absolutely not. No, you should not always do that. It's your decision, though. It's your decision, but I would not go with that theory. Will we receive a confirmation you received our intake form? Yes. Only if your overall average is failing. That is true too. So if you want to do the no questions asked and you feel that you can boost your score on any of the exams for which you had a low score, then that would be the one you submit for. You do pick the test you want to retake. You're welcome, Rebecca. But is the best choice the lower score? Sometimes it is.
Depends.
It depends. this is me. I can't tell you guys what to do. I really can't. But this is what I can say for myself. If I'm passing, then I'm going to leave well enough alone. So you can submit it, Luina, and then rescind it. But if at the end of all 5 exams you're passing, why even tempt fate? Just leave. Sometimes just, leave things be. Christine, so for the group taking the final on Monday, our retake day would be Wednesday. That is true. So that was Caitlin, and we just emailed you saying we're rescinding. Yes, and and I'm going to post an announcement so that way you don't forget. So if you're going to rescind, then I'm going to tell you to tell me which test you're rescinding. So which exam. Would we then retake the one we thought we had the best chance of doing better on? That is true.
That is true.
I don't know if I would, even if it's not the lowest, if you don't feel you would be successful at the score that's the lowest, but you feel that you would do better on an exam that you pass, that's your decision. I can't tell you how to navigate that, but I will just say, if you get a lower score than what you already had, that score stands.
Yeah.
I'm not sure how to pick. I can't tell you how to pick, baby. Otherwise that wouldn't be right. Because if you don't do well on that test, and I tell you to do this one, you'll be like, Ms. Hudson said to do this test. So this is where I have to step out and say, you're gonna have to, marinate on it and decide which one of these you want to do, if not do. But right now you have there's no skin in the game per se. You're just saying, this is what I would like to do. There is nothing to say that you have to own it right now. You don't own it until after the comprehensive. Then you'll know what you need to do moving forward. So up until this point, you're just saying, these are my wishes. You may choose after the comprehensive, this is not, I don't need this. And then that's what I'm saying. You have that 24-hour window to send me the information saying, you know what, I'm passing, I'm good, I'm moving on. Which dream? Which dream, Dianelle? I'm dreaming too.
And I think I know I talked with my students when we did our Q&A. Was that just yesterday? I guess it was. Mm-hmm. And they're asking the same question. I said, you look at your scores and then you look at the content. So if you really did poor on metabolism and nutrition, and now you feel you've taken care of some diabetic patients, you really feel good about that, but your really lowest score was perfusion, but that just killed you, I would go with what I feel so comfortable about, I can bring it up. I mean, but you have to decide. You have to decide. If you did poor on 2 tests, you felt good on the last one. Well, good. I'm glad you felt good on the last one.
I mean, this is the part where you guys do have to make these decisions, because we just can't. 77.5 is passing, but I can't tell you guys what to do. You have to feel comfortable with the final decision that you make. So, I can't tell you which one would be better for you. Even if you feel a test that you did good on already, this would be your best bet. Then okay, you go with that. But the grade's still gonna stand at the end of the day, and I think that's the key piece you need to understand. So the retakes have the same level of acuity as your lecture exams. There is not one is more hard than the other, but they're not the same exams. You can only retake one. You're cute, Dianelle. You can only retake one, but they're the same acuity. It's not designed for you to,
Fail.
Struggle. If you're studying for the comprehensive, this is already information you should have in your brain. So the retake should be easier because it's stuff that you have already put in your brain.
Again.
Mm-hmm.
Yeah.
And so I think sometimes you guys psych yourself out because you start panicking. And so if you don't panic, that would be the best thing to do.
Yep.
I agree.
Because what does panic do? It uses up all your resources that you need instead to study and focus. You can't focus when you're stressed and panicked. So, I know.
So, yeah. The last thing to clear up, I'm now circling back, although we're over the whatever time, but to get back to the platinum drugs, those are some of your more popular. They treat the majority of your cancer patients, so it'd be like your cisplatin. The last names of them are Platin, and so they have been used in other cancers like cervical cancers and things like that. But, they're one of the more common types of cancer medicines. But they're similar to your alkylating neoplastic agents or anti-neoplastic agents. So as long as we email you saying we want to rescind, that is true. And it's be after the grades post. That is true. Like, yes, cisplatin, that is correct. So they're very similar to the alkylating chemos or alkylating anti-neoplastic medications. You know what, Dianelle, I'll give you an A for definitely keeping it happy, or at least trying to keep it fun. So I like that. I like the positivity, even if that's not your. He goes, I'll take that one too. Keeping it fun.
That's like trying to rescind your mother button. Doesn't work.
So this is what I would say, and I've said this before. You guys know a ton of information. You do. The piece that's missing here, or the piece you guys have to work on more, in my opinion, and then Miss Gordon and Mrs. Johns can chime in, is how to apply that information. So everything in healthcare, doesn't matter whether you're doing respiratory, physical therapy assistant, radiologic technology, which is X-ray. You have to be able to apply the information based on the situation presented. So there is really there's not always a black and white. You can't categorize patients as either this over here or this over here, because your patients are primarily in between those, which is the gray area. So you may not like that piece, but in truth, when you're looking at, you have some signs and symptoms that are textbook, and then you may have some signs and symptoms that are atypical, but it's still related to a condition. So I would take my time, read each question, and then answer accordingly. And that's how I would do it. I would not spend a lot of time, energy, and effort saying it's only this over here or only this over here. And I think that's where you guys were getting stuck with the heat and the cold, the O2 or the epi. There was a couple of those, the shower, the rest, or the activity. So it depends on what the question is asking. And if it's asking for which of these interventions would be appropriate in the management of this patient, then you use the appropriate ones that fits in there. So don't go looking for zebras. So even if certain things don't necessarily work for all folks, it may be useful in others. So it is things, and that was the TENS unit that can be used to help with patients that have RA and some of the other conditions. So, just Just because it may not have worked in somebody that you know, or for you personally, it doesn't necessarily mean that it doesn't help. Does that make sense?
Yeah.
Would that be a fair assessment, Mrs. Johns and Mrs. Gordon?
I would say yes, because, you know, you do know a lot. And Ms. Hudson just said you have a lot of knowledge. You do. And take that, but you have to be able to apply it. And every patient's different, so it's going to, and you could, if you're working, you say, well, I saw them do this and that. But we're looking at a pretty perfect hospital here. The hospital we're working at right now and for testing is perfect. You have everything you need and you can do it right according to protocols. So apply it to what you've read and what you've been instructed that is appropriate for caring for that patient. I think application is key.
I agree.
Yeah.
Learn to trust yourself and the application that you're making. Just, not second guessing. I think that happens a lot. You'll have the right answer at first, and then you'll go off on a little rabbit trail and come up with something else. But I agree with everything that Ms. Hudson and Ms. Johnson said.
So yeah, that's you guys really do know the answer, but for some reason you start thinking of some of the strangest things out of the blue, and 98% of the time you will change a correct answer to an incorrect answer versus the opposite. So just once you make your decision, then just stick with it. Don't change, don't go with it after reading all the choices. So once you read all the choices, then make your decision. So that way you can check yourself to make sure you do have the right one.
Good, Patana.
I like that. All right. So I will send out a Zoom link for you guys for Saturday, because I think that's what I saw. And if it's not, then speak up now or forever hold your peace. All right, I will set it up for Saturday at 10. And then, I'll do the highly missed questions for exam 4. And then we'll move on. I cannot post it. I cannot post it. Yeah, I mean, it'd be no different. Yeah, it'd be no different than the last time. It's, it was just like the question, the person that has, if they have ulcerative colitis and, what's their problem? They have diarrhea. Okay, so what's the problem with the diarrhea? How does that impact the patient? So that goes back to that application piece. So, and it just, even if it wasn't ulcerative colitis, just think of any old person that may have had diarrhea. What are they at risk for? And the two things is dehydration and electrolyte imbalances. Okay, you guys know that part. Yeah, everyone's welcome to the Zoom sessions. There's no one left behind. So but your patients don't walk in and say, I have hypokalemia. No patient walks in and says that, or I have hyperkalemia, or I have dysentery. They don't. So how would that hypokalemia be displayed? So this goes back to fluid and electrolytes. What are signs and symptoms related to hypokalemia? The most common one is muscle cramps. So those are the things that they would report, that you would anticipate the patient reporting to you, and then you would also anticipate the patient being dehydrated. So dry mucous membranes, poor skin turgor. Does that make sense? So what I'm needing or asking you guys to do is to take those broader terms and put them into, or what the patient would actually look like. How would I know this patient is dehydrated? If it was a baby, how would that baby look? If it was, a child, what would the child look? What would the cap refill be? If this was an adult, how would they present? That's how you apply the information. So that's why when we talked about Cushing's triad, you guys know that it's bradycardia, hypertension, irregular respirations. And then I told you, give me some numbers of what this would look like and then why. What type of respirations would this be? Just besides irregular respirations, what respirations do we have? Any names for any irregular respirations? And that's why I do that, because you're looking for the broader sense where, in clinical, I see students look at the monitor, but it's like there's a complete disconnect. You see the numbers, but you're not able to put those pieces together. But this is why I say, how would the patient look? Because then when you are in clinical, wait, this isn't right. So, things of that nature. If you do have a cancer patient, and even if they are in hospice or, doing palliative care, and they have a DNR, things that would, what would you call the physician about and say, well, if I would be looking at it, I think this happened to be a number chart. So it gave you some lab values, and it asked, which of these would you report? And the patient had metastasis or something. It was a couple of metastases that was in there. But you would be looking for labs that indicate there is a new location of the cancer process. So you would be looking for those labs to indicate, this cancer may have spread in someplace else. Does that make sense?
Yeah.
Okay. So that's what you're going to see in clinical. So that's why these lab values are important. It's important that you move those lab values that you learned in second to third, then on to fourth, because those lab values mean things in certain situations. So when we get to Saturday, we'll look at that. But that's what these exams are when you're talking about the clinical judgment. It's not that you guys don't know stuff, because you do, but it's when you're presented with, okay, these are the pieces, and you're seeing them, you're not really sure what does it mean in the bigger picture.
And I'm going to add, make sure you get rest the night before. Okay. I found this yesterday, and I just copied it verbatim in some research I was looking at. It says, no matter how much studying you've done, you feel like you still need to do more. It is more beneficial to get a good night's sleep than to study until dawn the night before a test. Studies have found that the processes your brain goes through while you're asleep actually help you remember information better the next day. Your brain is bombarded with stimuli when you're awake, and it uses the time you are asleep to process everything. That's when it gets rid of unnecessary information and doubles down on remembering important things like all that stuff in your MedSearch textbook. I added that. Sleep is when it consolidates that information into a long-term memory. If you stay awake, your brain cannot go through this process.
I would definitely second that notion, because before I wrote for my NCLEX exam, I didn't study anything. I just went to bed early and woke up and ate breakfast, and I took the test.
Yep.
But I've done that throughout several areas. You have to give your brain time to digest everything you're shoving in it, and you have to study in smaller chunks. So do not spend Thursday, Friday, Saturday, Sunday reading every concept from repro all the way down to end of life every single day. Break that up over several days and start with the stuff or the information for which you were the weakest on, and that's going to be different for every one of you. I would not spend a whole lot of energy on things that I know solid. I would spend my energy and time on things that I did not know solid. That would be where I would start, and then move through the things that I knew hands down.
Absolutely. Absolutely.
So that's looking at time management and better utilization of your time. To answer your question, Rebecca Land, if you're still on the line, I'm going to dialogue with. She's gone. Dang it. No, she isn't. She's there. I'm going to dialogue with Miss Rattan to see what would work for their schedule, because I know they're being asked to sit in to help students get onto the on-site. So it may be Thursday, but I will see, because I don't want to conflict with Mrs. John's class. So I will keep the Monday group apprised. Okay. Any other outgoing questions, concerns? Oh, you know what? Let's not worry about HESI yet. Let's stay focused on this exam. I will address HESI after comprehensive. So one thing at a time. How do you eat an alligator? One bite at a time. Yes, Kensky. Go ahead, Kensky. Turn your mic on. We'll see. We'll see how it goes. I'll set it up for 3. I mean, heck, 3 hours went fast last week. I was surprised. But I mean, you know, it was more of what I was asked to do is to go over the highly missed questions. So, you know, we'll do that. And then, you know, if you have any other additional, I mean, I'll be more than happy. I don't know if Ms. Johns is available, but I'll email that out as well.
Is that on Saturday?
Yes, Saturday at 10.
I can.
Okay.
Sure.
So yeah, I was surprised that the 3 hours went quick. I was like, where did the time go?
Oh my goodness.
I mean, it literally did. I mean, wow. I think I started with end of life and PD and versus adult, and then we just went on from that point on. And I looked up, I think we took a 10-minute break. It was like only an hour left. I was like, where did the time go? So, all right, guys. So for now, just lay it down for today, and then, you know, get some rest, and then start tomorrow, start fresh. But today I would not try to sink another piece of information into my brain. I would just give my brain a mini break, and then I would restart this tomorrow. You guys are welcome. Any other closing remarks, you guys? Ms. Gordon, Ms. Johns?
No, I'll just say blessings to everybody. Y'all can do this.
Yep. Great job, everyone. Good to see my Northlake students again. I wish I could really see you. I need hugs, you know, one of these days.
You guys are welcome. PNC grades, I will get with the PNC faculty first before, you know, grades are released. So I need to see what their availability is. And I think that's just Mrs. Smith and Mr. Bobbitt. So